The most talented fellows were from India. There was no doubt about that. Again, I have a lot of esteem for your country, and I would like that this today be wonderful for you in this institution. Briefly, this institution has been built, in fact, 10 years ago, and fortunately or not, we forgot 1 0 on the line of the research building. So in fact, we spent 10 years to raise money for having a research building. But now we have first being able to say to the other specialties that it should be only cardiovascular center. And second, we were able to inaugurate it a few weeks ago. So now in this place, you have three cardiology departments, two vascular and cardiovascular surgery, and you have vascular medicine, hypertension, nephrology, and on the other side you have 3,000 square meters of research on in-cell units, which is in fact French NIH, coming from
so in 1977, when
Morning, yeah. So we'll start now the program schedule as per, we are already late, but I think one or two speakers, if they don't come, where is somebody should be here, whosoever. Just one small video which I want to show before we start. Dr. Kribier had done a welcome address in the last conference, so we could not get this because it has to be downloaded. I thought let us play this one. So can we have the audio? You have to stay here, please don't go down.
from other countries.
Video on volume.
This is Dr. Alain Cribier speaking from Rouen, France, sitting at my piano. And let me tell you that it's a great honor and a great pleasure to give you these few words of welcome address at the beginning of this conclave meeting. I must apologize, and I sincerely regret of not having been able to be physically present with you for various reasons. But I have seen the program, and I must congratulate Dr. Vivek Gupta for all the efforts and energy that were certainly necessary to build the program together with a number of conferences and video cases. It is covering all aspects of modern cardiology. I am sure that you will enjoy it very much, and I do hope that you will have many opportunities to share your experience and interact with a number of faculties, most of them being my good friends. Also, at this special period of the year, I would like to wish you a wonderful and peaceful year 2019. My friends, have a great meeting, and I hope to see you soon.
Okay, so let us start the topic. Let me introduce the program synopsis.
Dear friends and colleagues,
the program synopsis is that the first symposium is on coronary artery disease. The whole program has been designed only for the physicians and the interventional cardiologists, and we expected a lot of more people, but let's see, they will joining. The first topic was supposed to be by Dr. Amit Munjal. He is traveling from Hisar, so he will be reaching soon. And the second topic is Dr. Rajiv Agarwal, our great friend and very senior cardiologist from Delhi, and he will be talking about pharmacoinvasive treatment of ST elevation myocardial infarction. Dr. Subhash Chandra requested me to put him in the afternoon session, but in the meantime, I'll do some presentation, and our friend Dr. Pathak will do some presentation in this. So we'll finish this scientific symposium on coronary artery disease within half an hour. After that, we'll have a symposium on valvular heart disease, and our great friend Dr. K.K. Kapoor, one of the ace echocardiographer and clinical cardiologist from Delhi and Noida, working with us almost for the last 26, 25, 24 years for me. And he will be talking about diagnosis of valvular heart disease by echo Doppler, Dr. Kapoor. Then Dr. Manisha Chakravarti will talk about interventions in congenital heart disease. Our great friend Dr. Jyoti Muthu is here. He was just here, I think he must be out. Okay, he's there. He's a very important cardiac surgeon. And when I asked him how you operate small children, he said, when I was doing surgery, somebody noticed that he can operate very small incisions and stitches. So they advised him to go for a congenital heart surgery, and one of the important cardiac surgeon with very good success rate and getting a lot of patients internationally. So he'll be talking about recent advances in teratology of fellow, which is a very important subject, and one of the most common congenital heart disease surgery requiring. After that, we'll have symposium on diabetes, obesity, artificial intelligence, and Dr. Rakesh Gupta, who is our friend and physician in Apollo, he will be talking about management strategies. Bariatric surgery, Dr. Arun Prasad, Dr. K.P. Pandey, our great friend and cardiovascular thoracic surgeon, will be talking about how to manage diabetic foot. Dr. Anurag Agarwal is an important person. He was the head of CSIR. Our great friend, he is having a lot of interest on artificial intelligence. So he'll be talking about, you could have shown the scientific program here on talking about this artificial intelligence in healthcare. And this was all pre-lunch, and post-lunch I will announce later on symposium on heart failure. We'll have symposium on coronary intervention. Heart failure will be, of course, R.D. Yadav will be talking about. Then symposium on TAVI and coronary interventions, and then we'll have valedictory function. So I request all the speakers who are here in the early morning, it's a working day, but my sincere request that they can stay back the whole day, and especially Dr. Rajiv Agarwal, who is talking in IECR for the first time. I'm thankful to him to accept this talk. So may I start with Dr. Rajiv Agarwal talk. Please welcome him on the dais, and he will be talking, he will introduce a little more about himself, I would say, maybe something which I have missed, and he will talk about, and then we'll have his slide presentation. So acute coronary syndrome is starting. It's Facebook Live, it's a YouTube Live. It's going on Clarnet. Clarnet is a digital platform. We have they said they have 2.5 lakh doctors, so they are doing marketing. So this online is going. So we should not be disappointed, especially the speakers get disappointed when the crowd is not there. But I personally feel that if it is online, it's recorded, it will be shown Facebook again and again. And this lecture, which is recorded, can be shown by the speakers themselves and our society in various other forums. It can go on YouTube Live, and I'll put all of the lectures. I'll see that all the lectures with the speaker's photograph will go on my YouTube channel, and if they want, they can use it for other platform, because it's all learning, and the learning does not mean that only the counting the faces. So counting the heads not important. It's a digital word, and when our Honorable Prime Minister Narendra Modi speaks, then a lot of people are listening, and you see such things are happening now. So counting heads is now the past, or the year of the past, and Dr. Rajiv will agree with me. So we have to give a good applause for him to be here, and I will just put, I think you have the talk here, you can help him to get his talk. Thank you.
Thank you, Dr. ये नहीं फार्माको इन्वेसिव था भी, इन्होंने मेरे से तो ले भी दिया था, सॉरी. So while they are setting up the slides, thank you, Professor Vivek Gupta, and thank you to IECR for...
Can I request Dr. S.N. Pathak to be on the stage as a chairperson along with Dr. Kapoor? Sorry.
No.
Because it is going recorded now. Sure. Full, little about where you worked earlier and now.
So call these.
डबल क्लिक करके
बस
कुछ नहीं करना होता है
और कुछ नहीं
सर
करना
नेक्स्ट कर लीजिएगा यहाँ से
हाँ कर लेंगे वो तो कर लेंगे
थैंक यू सर
Good morning, friends. I am Dr. Rajiv Agarwal, and I am Principal Director of Cardiology at the Max Smart Super Speciality Hospital. And it's wonderful to be here amongst you for this hybrid course. I'm the opening batsman, and I hope and trust the hall will fill up. But this is a hybrid course, so as Professor Gupta said, we are all learning. So I work here at Max, and I'm a product of All India Institute and did a fellowship in interventional cardiology in UAB way back. I've been on the faculty of AIMS and then have worked in Batra Hospital for a long time. So last 5 years I am at Max. That was my obligatory introduction. And so the topic that I have been given is pharmacoinvasive therapy, and I think that's quite an important subject because you know, in India, as in even developed world, not every patient with acute myocardial infarction reaches a PCI capable hospital. This is even more so in India, but it is true even in the developed world. And then what to do with these patients? Does every patient then need to be transferred for a PCI because it is superior, or should we thrombolize the patient? If we thrombolize the patient, should we end there? These are very important questions because acute myocardial infarction remains the most important cardiac emergency that we face, both in our part of the world and in possibly in Europe also, this being an Indo-European course. So just to put it in perspective, a 45-year-old woman, diabetic, presenting to a non-invasive center with chest pain of 1 hour duration with 4 millimeter anterior ST elevation, currently having her periods. That is just there to emphasize that periods are not a contraindication to thrombolysis. And she's stable with no evidence of LVF. She is about 2 to 3 hours away from an invasive center where she could have angioplasty. So for this patient, what is the best treatment? Should this patient be transferred for primary PCI, given that we know that primary PCI is superior to thrombolysis if done in a timely fashion? Or should you give the patient thrombolysis and only transfer if the patient is crashing, in shock or LVF? Or you give thrombolysis and transfer if the ST segment does not settle, or you give thrombolysis and transfer even if the patient is settled and therefore you plan to do a routine angiography. So we'll come to the answers later, but basically the pharmacoinvasive approach could be characterized as lyse the patient today and stent tomorrow, because the patient is coming at a time when or to a place where he is not being offered an immediate primary angioplasty, or he is not accepting it, he doesn't understand what is happening. So time being muscle, we need to protect this patient, and so the patient should be thrombolized. That will give at least some benefit. And then even if the patient is settled by this means, even if he shows clinical evidence of reperfusion, then we should transfer the patient to a PCI-capable center by a good, safe ambulance service, and within 3 to 24 hours, we should do a routine angiogram with the intent to do primary angioplasty if there were significant culprit lesions in the patient. So that is what is pharmacoinvasive therapy, lies today and stent tomorrow, and along with that you have to give all the medicines including dual antiplatelet. Since you are giving very intensive thrombolytic therapy, then clopidogrel might be chosen, although ticagrelor could also be used in these patients, and the other therapies like statin, beta blockers, etc. to be given. So, of course, we know that primary PCI, if done in a timely fashion, scores over fibrinolysis. So when the patient comes to me in my hospital, which is a tertiary hospital with 24/7 cover for primary angioplasty, we would first offer the patient a primary angioplasty because it is superior in multiple trials over fibrinolysis. Fibrinolysis with streptokinase will give you reperfusion in about 50% of patients. Even with the second or third generation lytic agents, you might be able to succeed with 60 to 80% of patients. So primary PCI is superior, especially in high-risk cases, shock, large infarct, or delayed presentation, but it is not widely available. There is time delay, and it is expensive. Majority of STEMI patients still do not get primary PCI in India. Hence, thrombolysis remains our default strategy. Thrombolysis might work well in uncomplicated cases which present within 3 hours, but then the success is not assured, only 50% with streptokinase. Hence, one should be prepared for a rescue PCI in patients with failed thrombolysis. It's not that you do fire and forget that you've done thrombolysis and that's the end of it. And even in patients who are improving, they are often left with critical residual lesions. So a strategy of routine coronary angiography should be done expeditiously, which is the pharmacoinvasive strategy. And are our guidelines different from the West? So we can look at the revascularization guidelines, and I'm just showing the European guidelines, which are quite well known to this audience. And basically, if the patient can be offered a primary angioplasty within 2 hours of first contact. So either the patient has come to a hospital with 24/7 primary PCI cover, or the patient can be quickly shifted, then the patient should be offered a primary PCI. For all other patients, it is considered that they should be sent for fibrinolysis with the best available agent. So consider drugs like tenecteplase and alteplase in preference to streptokinase. And then these patients, even if they are settled, even if they are showing ST resolution, they should be transferred for routine angiography and PCI. So that is in summary what it is. And but this entails a lot of time pressure, and often we are not able to meet these time goals. These are the important time targets. You should do an ECG within 10 minutes. Maximum delay from first medical contact to wire crossing, that is sort of door to needle time, door to balloon time would be 120 minutes. And so variously from 60 to 120 minutes, you have to complete your procedure. And data suggests that even in developed countries, 1/3 to 1/4 of the patients undergoing primary PCI are not getting treated within these timelines, leading to higher mortality. The situation in our country is obviously worse, and treatment delayed is actually treatment denied. We know that there is a very tight correlation between delay in treatment and increase in mortality, and it is treatment denied because you do have an alternative which is reasonably good in the form of thrombolysis, and in order to get the better treatment, you are giving a delayed treatment which often leads, goes to the detriment of the patient. So, therefore, what to do after thrombolysis? You need to identify failed reperfusion and transfer such patients for immediate rescue PCI if they have shock or recurrent VT, or if they fail to show ST segment resolution. But even if patient is settled, then you should consider routine early PCI. So, as opposed to thrombolysis alone, multiple trials, and these are now somewhat dated, have shown that doing routine early angiography will be beneficial. So many trials are listed here. So pharmacoinvasive strategy is better than thrombolysis alone. And the STREAM trial, which is also now somewhat dated, has shown that if you cannot do a primary PTCA within 60 minutes of the patient arriving, then it may be beneficial to go for thrombolysis, be it with half dose or with full dose, and then go on to early angiography, which is the pharmacoinvasive strategy. So it shows that the pharmacoinvasive strategy is at least numerically superior. So you could call it equivalent, or you could call it slightly superior. There is a slight increase in intracranial bleed, though, which was there in the STREAM trial. So the CSI position statement on STEMI, of course, it acknowledges that we are very underserved. We can look at big cities, we can look at small towns, we can look at villages. Certainly in villages, even thrombolysis might be a big deal. Even doing an ECG might be a big deal. And so you give the best available treatment. But even in a city like Delhi, where there are cath labs at every kilometer now in the city, there'll be many situations where the patient cannot get a primary PTCA. There may be patient refusal, family refusal, lack of awareness, inability to arrange finances, at least on the spot, and many other things. So therefore, if there is going to be a delay, either because of indecision or due to other reasons, then do offer the patient hospital-based thrombolytic therapy and round it off with pharmacoinvasive therapy rather than going for a delayed primary PCI at 3 hours. So that is the point which we need to make. And 50% of our patients are still not receiving any reperfusion therapy, so provide at least minimum standard of care. Having said that, thrombolysis is still the default strategy in India, although CREATE registry and Kerala ACS registry are somewhat old now, but still thrombolysis far outstrips PCI. Thrombolysis 58.5%, PCI 8%. And the most common thrombolytic agent used in Indian setting is streptokinase. So one priority might be of course, to increase the penetration of primary PCI, but also to improve the way we give thrombolysis and use the newer drugs which will give you better reperfusion rather than streptokinase alone. And what is the developed world doing? Even there, although so this is the FAST AMI data sampled at 5-year intervals from 1995 out to 2015, so 5 intervals are there. And whereas initially it was thrombolysis which was the maximum, now the vast majority of patients are getting a primary PCI. Still 6% of patients are getting thrombolysis even in 2015. But look at the figure at the bottom, PCI after lysis, which was very infrequent in 1995, but is now 87%. That is, routine PCI after lysis or thrombolysis is steadily increasing and is currently offered to almost all patients. So therefore, the standard of care, if you are giving thrombolysis, is to do a pharmacoinvasive treatment. About 1/3 of the patients who are getting primary PCI, even in FAST-MI, that is the French Registry of Metropolitan France, are getting it in a delayed fashion. So 30% will get it beyond the timeline of 2 hours, whereas 60% would get the primary PCI within 2 hours. And these patients have nearly double the mortality compared to those who are getting a primary PCI within the 120 minutes period. So therefore, pharmacoinvasive strategy remains relevant in the developed world and in the developing world. It's not just strategy of deprivation. We have data from the Indian STEP AMI study from Tamil Nadu with Dr. Ajit Mulasari pioneering it. And this was observational multi-center prospective study, 200 patients followed for up to 2 years. 45 patients chose not to go for immediate PCI. So this was not a randomized study really. And 150 patients went for primary PCI. The outcome was better in the primary PCI group, no doubt, but the differences were small and they reduced from 30 days to 2 years. So a pharmacoinvasive strategy results in outcomes that were comparable with primary PCI at 2 years, suggesting that it might be a viable option in India. So this is the actual data. So no doubt the odds ratio is not so great for pharmacoinvasive therapy, 2.87, but the p-value is not significant. So not significant difference. And then the odds ratio for the difference in outcome has reduced at 2 years. So, and also for death and for the combined endpoint. So at least in patients who are not accepting a primary PCI, even if they reach a PCI capable center, we should still be offering them thrombolysis. Much the same thing has been looked in a more contemporary trial in, again from France. This I think is from China actually. 344 patients and expected PCI delay. And there it was found that if you gave half-dose lytic therapy to them, followed by a pharmacoinvasive therapy, then you will achieve similar TIMI flow grade, similar TIMI myocardial blush, similar ST segment resolution, similar size of infarct on MRI, and similar clinical outcomes by and large, death, reinfarction, heart failure, stroke, etc. There's only some increase in minor non-intracranial hemorrhage bleed. So give these patients who are not feasible for immediate primary PCI half-dose lytic, then 3 to 24 hours later, you can carry it forward with a routine angiography followed by plasty. So therefore, the question which we had posed, and I think the answer should be clear, to my mind it is, this patient who will not be able to get primary PDCA within the window period should be given, and she's a young patient, should be given full dose lytic, and she should be transferred to a PCI center for PCI within 3 to 24 hours. I would choose a third generation lytic rather than streptokinase in these patients. So there are geographical constraints, there are logistical constraints, economic constraints, patient preference. All of these lead to many cases not being offered primary PCI, although it is the preferred strategy. In these patients, instead of doing a delayed primary PCI, do thrombolysis with best lytic or even with streptokinase with plan for routine early transfer for CAG or PCI thereafter. Thank you for your attention.
Early intervention, whatever way, and of course primary PTC is always better if it can be done in a window time. So we'll have actually in the session of coronary artery disease, we will have some discussion after one more talk by Dr. Tanuj Bhatia, who will be covering Amit Munjal, but his topic is different. It's stable coronary artery disease. There has been a lot of discussion about